Good morning, friends. Today we are on a seventh day of reading Oxford Handbook of General Practice, and I am your study buddy, Dr. Sesha, and we are preparing for MRCGP AKT Step 1 examination. And we are on page number 243, chapter Cardiology and Vascular Disease, Atrial Fibrillation. Common disturbance of cardiac rhythm. What is atrial fibrillation? It's a common disturbance of cardiac rhythm characterized by rapid, irregular, narrow QRS complex tachycardia with the absence of P waves. So you will not be able to find P waves in a atrial fibrillation. May be episodic, paroxysmal, or chronic. Affects 1.5 to 2% of UK population. Prevalence increases with age less than 0.5% age 40 to 50 years, 5% in more than 65 years, and 10% in more than 75 years. Causes usually idiopathic, may occasionally be due to atrial dilatation, example in association with a valve disease, inflammation, fibrosis of the atrium, or increase in muscle mass, that is example left ventricular hypertrophy secondary to BP, high BP, or cardiomyopathy. Acute atrial fibrillation. It may be precipitated by an acute infection, alcohol intake, surgery, electrocution, MI, pericarditis, pulmonary embolism, hyperthyroidism. Presentation. Often it is asymptomatic, detected if chance finding of the irregular pulse or following a stroke or TIA. If symptomatic, then patient may have palpitation, breathlessness, dizziness, postural hypotension, or chest discomfort. Examination aims to confirm atrial fibrillation and exclude the underlying causes. Check for first pulse rate and rhythm. If the apex in atrial fibrillation, apex rate will be more than the radial pulse in atrial fibrillation. BP, check the BP, heart size, heart murmurs, sounds, JVP, signs of left ventricular failure. Check for signs of systemic diseases like anemia and thyrotoxicosis. So assess X severity. For severity of atrial fibrillation, the EHRA score is 1. No symptoms, grade 1. 2. Mild symptoms, normal activity not affected. 3. Severe symptoms, normal activity is affected. 4. Disabling symptoms, normal activity is discontinued. Investigations. ECG. If paroxysmal AF is suspected but not captured on the ECG, then consider 24-hour ECG monitoring or a cardiac memo. Blood test. In the blood test, first you have to rule out anemia and thyrotoxicosis and electrolyte imbalance. So, reversible causes. FBC, you need to do a full blood count, urea and electrolytes, EGFR, TFT is thyroid function test, anemia, hypothyroidism, electrolyte imbalance, trigger and EF. Renal function test affects the drug of choice. So you have to do an EGFR. Chest X-ray to evaluate the size of the heart and identify a lung disease. Echocardiography to check the left atrial size and left ventricular function. Management. If acutely severe or compromised, admit to the hospital. Rate limitation. If the heart is beating too fast, it cannot refill before the next beat and becomes an inefficient pump. So controlling ventricular rate in atrial fibrillation allows the heart to work more effectively. The choice of drugs as if is given in figure 9.3. Offer as the first line strategy to people if with atrial fibrillation, except if. So rate rate control, you have to do rate control in all the cases as first line, except in some cases like if atrial fibrillation has a reversible cause like alcohol binge or chest infection, you will do rhythm control. Heart failure due to atrial fibrillation, if there's a secondary heart failure due to atrial fibrillation, you will control the rhythm first. New onset atrial fibrillation, control the rhythm. Atrial flutter suitable for ablation, you control the rhythm. Rhythm control would be more suitable. In whichever other causes, rhythm control would be more suitable. Restoration of sinus rhythm, that is rhythm control. Successful cardioversion is most likely in young patient with a structurally normal heart where duration of atrial fibrillation is less than 12 months. Consider referral for DC cardioversion. So in rhythm control, there are drugs which control the rhythm, and also there is DC cardioversion. So you have to consider referral for DC cardioversion if the heart failure is associated with atrial fibrillation. Recent onset atrial fibrillation with low risk of recurrence, that is obvious precipitant, example pyrexia, alcohol, post-op, and no structural heart disease. intolerable symptoms despite adequate rate control, high risk from anticoagulant therapy. So otherwise, you offer a rate control as the first line strategy. Patients who are started on amiodarone, patients are usually started on amiodarone prior to a DC cardioversion and 1 year following the procedure to maintain a sinus rhythm. So, atrial fibrillation, the drugs. First line, beta blockers, example bisoprolol, not sotalol, only bisoprolol. Rate limiting calcium channel blockers, example diltiazem, digoxin, but only if sedentary, none or very little physical exercise. Patient is not on any high risk physical activity. So first line drugs, which either a beta blocker or a rate limiting calcium channel blocker or a digoxin. Second line, if still he has ongoing symptoms, then second line drugs are beta blocker plus diltiazem or beta blocker plus digoxin or diltiazem plus digoxin. Do not use amiodarone for long-term rate control. Amiodarone is a rhythm control drug. Do not use it for long-term rate control. Choice of drugs for rate limitation in atrial fibrillation. These are the choice of drugs for rate limitation. Prevention of thromboembolic complications. Page 536. Atrial fibrillation is associated with increased risk of peripheral thromboembolism, including stroke. There is a 5 times increased risk. All patients with valvular atrial fibrillation or a moderate or high risk patient with non-valvular atrial fibrillation should be considered for anticoagulation with warfarin or a direct oral anticoagulant. Example, rivaroxaban or apixaban to decrease the stroke risk. Do not offer aspirin for atrial fibrillation. Weigh the risk of thromboembolism against the risk of bleeding. The Neil University Decision Support Tool may be useful for anticoagulation. So in this, first we have the Chadwa score. If they have to be given anticoagulation or not, and again the risk, the bleeding risk score or the orbit score, which will decide let us decide whether we have to give anticoagulation or not. Pill in the pocket approach to paroxysmal atrial fibrillation. Consider self-medication with a beta blocker PRN, example atenolol 50 to 100 milligrams OD, if infrequent symptomatic paroxysms and no history of left ventricular dysfunction or a valvular heart disease or ischemic heart disease is present. Systolic BP is more than 100 and a resting heart rate is more than 70, able to understand when and how to take the medication. So in all these scenarios, you can give a beta blocker PRN in case of a paroxysmal atrial fibrillation. Refer to cardiology. When do you refer to cardiology? In all these cases, E is emergency, U is urgent, S is soon, R is routine. In an emergency, only if acutely unwell or with hemodynamic instability with atrial fibrillation. For consideration of for cardioversion. So all the reversible or acute causes where you need to consider for cardioversion, either it's emergency or urgent. Abnormality on an echocardiogram requiring referral. So it is soon or routine. Inadequate rate control using standard drug combinations, still symptomatic despite rate control, or frequent attacks of paroxysmal AF. In this case, you have to refer either soon or routine. Age is less than 30 years, soon or routine. Heart failure, soon or routine. So even if it is a heart failure with atrial fibrillation, it is a soon or routine referral, not an emergency or urgent referral. Atrial flutter. ECG shows regular sawtooth baseline at a rate of 300 beats per minute with a narrow QRS complex tachycardia superimposed at a rate of 100 or 150 beats per minute. Manage as per atrial fibrillation. Specialist drug treatment may differ. Driving and arrhythmias. Stop driving if arrhythmia has or likely to cause incapacity. Group 1 license. Restart driving when underlying cause is identified and arrhythmia is controlled for more than 4 weeks. Inform the DVLA only if underlying cause is not found and arrhythmia is not controlled for more than 4 weeks. Group 2 license, inform the DVLA. License is restored if underlying cause is found and arrhythmia is controlled for more than 3 months. So for group 1 license, it's only more than 4 weeks. That is, um, then you have to inform the when arrhythmia is controlled for more than 4 weeks, then only you can restart driving. And if arrhythmia is not controlled more than 4 weeks, then you have to inform the DVLA. But in case of group 2 license, you have to inform DVLA initially, and license is restored if underlying cause is found, arrhythmia is controlled more than 3 months, plus LV ejection fraction is more than 40%. So initially you have to inform DVLA and stop driving. License is restored only when more than the cause is found, arrhythmia is controlled for more than 3 months, and LV ejection fraction is more than 40%. Next topic is bradycardia. Heart rate is less than 60 beats per minute. Presentation. Bradycardia. Heart rate less than 60 beats per minute. Presentation. Often as an incidental finding but may present with faints or blackouts, drop attacks, dizziness, breathlessness or lack of energy. Examination. Slow pulse rate, normal or low BP, plus or minus evidence of secondary heart failure. There may also be symptoms or signs associated with any disease. Investigations. For bradycardia, you do an ECG, 12 lead is resting ECG. Ambulatory ECG may be helped with diagnosis of intermittent bradycardia, example like sick sinus syndrome. Blood tests. In bradycardia, you do thyroid function test, a full blood count, ESR, urea and electrolytes, LFTs, digoxin levels if he is taking digoxin. So, digoxin can precipitate bradycardia attack. So, you need to check digoxin levels if a patient is taking digoxin. Sinus bradycardia. Sinus bradycardia is constant bradycardia. The P waves are present. The PR interval is less than 0.2 seconds, 1 large square. Causes. See, in this it is normal. ECG is normal, only the rate is less. So physiological cause like in athletes, vasovagal attack, drugs, example beta blockers or digoxin. If a person is taking beta blockers or digoxin, inferior MI, there will be bradycardia, sick sinus syndrome, hypothyroidism, hypothermia, increased ICP, and jaundice. Increased intracranial pressure and jaundice. Management. Admit acutely if symptomatic. Refer for cardiology opinion if asymptomatic, but heart rate is less than 40 beats per minute despite treatment of reversible causes. So you need to refer to cardiology only when, even if the patient is asymptomatic but heart rate is less than 40. But if patient is symptomatic because of bradycardia, you need to admit. AV nodal block or AV block. There could be an AV block. Causes are ischemic heart disease, drugs, digoxin, verapamil, myocarditis, cardiomyopathy, fibrosis or Lyme's disease, which is very rare. Can cause AV block or heart block. Types of heart block. First degree heart block. Fixed PR. In the first degree heart block, there will be a fixed PR interval which is more than 200 milliseconds or more than 1 large square. That is more than 0.2 seconds or more than 1 big square. The PR interval will be prolonged, but it will be fixed prolonged. That means in all the beats, it will be the prolonged PR interval. That is only first degree heart block. Second degree heart block. Mobitz type 1 or Wenchback block. Here, there is progressive lengthening of PR interval followed by a drop beat. So, they will be progressively increasing duration of the PR interval. Mobitz type 2, constant PR interval also in this, like in first degree block, with regular drop beats. 2:1, every second beat is dropped. Consider drug toxicity. 2:1 is seen in digoxin toxicity. Third degree block or complete block. PP intervals are constant, RR intervals are constant but not related to each other. Management. Untreated second or third degree heart block have more mortality of 35%. Refer all patients to cardiology even if asymptomatic. If symptomatic, if BP is less than 90 millimeters of Hg, systolic, left ventricular failure is present, heart rate is less than 40 beats per minute. This is symptomatic. In symptomatic heart block, so admit as an emergency, and if asymptomatic, refer to cardiology. If symptomatic, that is there is hemodynamic instability, admit as an emergency. Give IV atropine. In bradycardia, you give IV atropine and oxygen if available while awaiting admission. Stroke Adams attacks. Cardiac arrest due to AV block results in sudden loss of consciousness and some limb twitching due to cerebral anoxia. The patient becomes pale and pulseless, but respiration continues. Attacks usually last 30 seconds, although occasionally are fatal. On recovery, the patient becomes flushed. Refer to cardiology if you have suspected it. Sick sinus syndrome. Due to sinus node dysfunction causing bradycardia plus asystole, sinoatrial block, complete heart block, AVF, atrial fibrillation or SVT alternating with bradycardia, tachybrady syndrome. So this is sick sinus. This sinus is sick. Okay, it can either cause a bradycardia plus asystole, or it can cause a complete heart block, or it can cause a tachybrady syndrome. Common among the elderly patient. If symptomatic, heart rate less than 40 beats per minute or pauses more than 3 seconds on ECG, refer to cardiology for pacemaker insertion. Sick sinus syndrome, you need to refer for pacemaker insertion. Pacemakers electrically stimulate the heart to beat. Indications are symptomatic bradycardia is there, second or third degree heart block, suppression of resistant tachycardia. There is a tachycardia which is resistant. To suppress that, you need a pacemaker. Insertion. Pacemaker box is attached under the skin of the chest, usually medial to the left axilla. Under local anesthesia, the wires are fed into the great veins of the chest and thus to the heart under an X-ray or ultrasound guidance. Types classified according to chamber paste. So pacemaker, that is either it's an atrial pacemaker, ventricular pacemaker or dual chamber pacemaker. Chamber sensed, atrial, ventricular or dual chamber. Mode of responding to sensing, inhibited output, or is it triggered or inhibited and triggered, that is dual. So thus a VVI pacemaker both paces and senses the ventricle in inhibited mode, that is the ventricle beats spontaneously. If the ventricle beats spontaneously, the pacemaker will not fire. So it is in the ventricle, it will pace the ventricle and senses the ventricle. It's a BVI pacemaker. ECG changes with a pacemaker. If a pacemaker is in operation and a pacing spike, a vertical line is seen on the ECG. In devices pacing on demand, a spike will not be seen if the natural rate is in excess of the rate seen on the pacemaker. Okay, so this is on demand pacing, that is whenever there is a either a bradycardia or a tachycardia, then only the device will pace. So in that case, when there is a normal rhythm is going on, there won't be an excess. Natural rate is in excess of the rate set on the pacemaker, the spike will not be seen. When there is a bradycardia, then the pacemaker will be pacing and then only the spike will be seen. Lifespan. Pacemakers last for 7 to 15 years. Regular checks are made by the pacemaker clinics to ensure the pacemaker remains operational. Reprogramming through the skin is possible. Batteries can be changed via a small surgical procedure under local anesthetic. Driving and arrhythmias. Driving with a pacemaker. Inform the DVLA and insurance company. Stop driving for 1 month after insertion. Pacemakers must be removed after death before cremation can occur. A fee is payable. Infective endocarditis. New murmur plus fever. Endocarditis until proven otherwise. You have a new murmur on auscultation and you have a fever, it is infective endocarditis until proven otherwise. Infective endocarditis occurs when there is an infection of the heart wall, mitral, more than aortic, more than tricuspid, more than pulmonary. The wall may be normal, 50% may be associated with IV drug abuse, rheumatic, degenerative wall, congenitally abnormal wall, or a prosthetic wall. Uncommon but consequences may be disastrous, often detected and often detected late. Causes. Common organisms are Streptococcus viridans and Staphylococcus aureus. Non-bacterial causes are SLE and malignancy. Presentation may be acute with an acute heart failure or subacute course worsening over the days or weeks. Symptoms or signs. Infective. In case of infective causes, there will be fever, weight loss, night sweats, malaise, lethargy, clubbing, splenomegaly, anemia, mycotic aneurysms, heart murmurs, plus heart failure, embolic, stroke, lung abscesses, right heart endocarditis, vasculitic, microscopic hematuria, splinter hemorrhages, osseous nodes, painful lesions on the finger pulps, Janneweis lesions, palmar macules, rot spots, retinal vasculitis, renal failure. High risk patients, those with acquired valvular heart disease with stenosis or regurgitation, valve replacement, structural congenital heart disease including surgical corrected or palliated structural conditions but excluding isolated atrial septal defect or fully repaired ventricular septal defect or fully repaired patent ductus arteriosus and closure devices that are endothelized. So this is excluding ASD, BSD and PDA which has been repaired, but any other structural congenital heart diseases including surgical collected cases will be at high risk patients if they acquire endocarditis. Hypertrophic cardiomyopathy, previous infective endocarditis. When to suspect infective endocarditis? Have a high risk of suspicion and admit for as an emergency for further investigation if there is a febrile illness and a murmur of new valvular regurgitation, regurgitant murmur. Febrile illness plus a pre-existing high risk cardiac lesion and no clinically obvious site of infection. Febrile illness associated with any of the following: predisposition plus recent intervention with associated bacteremia like a dental work or a surgical procedure. Evidence of a congestive cardiac failure, new conduction disturbance, vascular immunological phenomenon. Example, it is an embolic event or the rot spot, splinter hemorrhage, Janneweis lesions, osseous nodes, new stroke, peripheral abscess, renal abscess, splenic abscess, cerebral or vertebral abscess of unknown cause, protracted history of sweats, weight loss, anorexia, malaise, and at risk of cardiac lesion, new unexplained embolic event like CVA or limb ischemia. Investigations in primary care if non-acute presentation. First, you have to do a blood test. Non-specific signs of infection like leukocytosis, increased ESR or CRP, ECG, 10% develop a conduction defect, see chest X-ray. Management. Admit if emergency is suspected. Avoid starting antibiotics prior to admission as this might cause delay in diagnosis by rendering the blood culture sterile. Hospital treatment. Once confirmed, the treatment is with prolonged IV broad spectrum antibiotics less than 2 weeks. Prognosis. 80% have more major complications during admission. Example, heart failure. Valve replacement may be required, especially if endocarditis is on a prosthetic valve. 16 to 27% die. Those with endocarditis affecting a prosthetic valve have poor prognosis. Other factors predicting poor prognosis in infective endocarditis are infecting organism. If it is Staph aureus, mortality is 30 to 40%. If it is Streptococcus viridans, only 10% mortality. Increased age, aortic valve involvement, associated heart failure is there. CNS complications, comorbidity like diabetes. Prevention of infective endocarditis. Current guidelines advises against routine antibiotic prophylaxis because there is no consistent association between having an interventional procedure and development of infective endocarditis. Regular toothbrushing presents a greater risk of infective endocarditis than a single dental procedure because of repetitive exposure to bacteremia with oral flora. Clinical effectiveness of antibiotic prophylaxis is not known. Antibiotic prophylaxis against infective endocarditis may lead to a greater number of deaths due to fatal anaphylaxis than a strategy of no antibiotic prophylaxis, and this is not cost effective. So nowadays we are not supposed to give any antibiotic prophylaxis for any dental procedure or any procedure for infective endocarditis. Only treat when it is diagnosed. Advise instead importance of maintaining good oral health, symptoms that may indicate infective endocarditis and when to seek expert advice, risk of undergoing invasive procedures including non-medical procedures such as body piercing or tattooing. Do not offer chlorhexidine mouthwash as prophylaxis against infective endocarditis to people at risk undergoing dental procedures. So you cannot even give chlorhexidine mouthwash. Rheumatic fever, myocarditis and pericarditis. Rheumatic fever. There has been a dramatic decrease in incidence of rheumatic fever in the industrialized countries since 1950s, but recently numbers have increased. Rheumatic fever is still an endemic disease in developing countries. Peak incidence is 5 to 15 years of age. Cause: rheumatic fever is due to an abnormal immunological response to beta hemolytic streptococci infection. Example, 2 to 4 weeks after a sore throat. Its importance lies in the permanent damage caused to the heart valves in some of those affected and subsequent risk of endocarditis. Diagnosis can be made if revised Jones criteria are met. We will check that in table 9.7. Management. If suspected, refer for a specialist care. Specialist management includes evaluation of the heart lesions with echo, bed rest, penicillins, symptom control, analgesia, sedatives for chorea, anti-inflammatory agents Anti-inflammatory agents such as corticosteroids and aspirin may be used to try decrease the complications of carditis, but their use is controversial. Prognosis. So in rheumatic fever, you are only supposed to diagnose the patient and then send them for specialist referral. So 60% develop chronic rheumatic heart disease. More than 70%, that is 70% people have mitral valve involvement, 40% have aortic valve, 10% tricuspid, 2% pulmonary. Likelihood correlates with the severity of initial disease. Recurrence may occur after further streptococcal infection or be precipitated by either pregnancy, combined hormonal contraception. Revised Jones criteria for diagnosis of rheumatic fever. Requirements for diagnosis of rheumatic fever. Evidence of previous streptococcal infection, scarlet fever, positive throat swab, and or increased ASO titer that is more than 200 units per ml. So this is an evidence of previous streptococcal infection, and two major criteria or one major and two minor criteria. So what are the major criteria? Major criteria are CREAM, carditis, rheumatic, sorry, no, it is major criteria is Jones, uh, joint, heart, uh, N is nodules, E is erythema marginatum, S is Sydenham's chorea. So there is carditis, 40 to 70% patients, arrhythmia, new murmur. Either you have an arrhythmia, new murmur, pericardial rub, or heart failure, conduction defects. Migratory polyarthritis, fleeting, 75%. Red tender joints, Sydenham's chorea, St. Vitus dance, 10%. Subcutaneous nodules, 2 to 20%. Erythema marginatum, 2 to 10%. So most common is carditis and migratory polyarthritis. Minor criteria: prolonged PR interval on ECG, but not if carditis is one of the major criteria. So if you have carditis and then you have a prolonged PR interval, it cannot be considered as a minor criteria. Arthralgia, but not if arthritis is the major criteria. Fever, increased ESR or CRP, history of rheumatic heart disease or rheumatic fever. Secondary prevention. So once a patient is having rheumatic fever, what do you have to do? Penicillin 250 milligrams BD per orally or sulfadiazine 1 gram OD, 500 milligrams OD for patient less than 30 kgs for less than 5 years to prevent recurrence. You have to give for less than 5 years to prevent recurrence. Duration of prophylaxis is dependent whether there was carditis in the initial attack. No cardiacis continue for 5 years. If cardiac involvement is there, continue until the age of 25 years or longer. Acute myocarditis. Inflammation of the myocardium may be present in a similar way to MI or with palpitations. Causes are viral infection, example Coxsackie virus, diphtheria, rheumatic fever, and drugs. Management. Admit for specialist cardiologist care. So, when there is a myocarditis as a diagnosis, you admit for specialist care. Treatment is supportive, some recover spontaneously, other progress to intractable heart failure requiring transplantation. Pericarditis. Pericarditis is a sharp, constant sternal pain relieved by sitting forwards. May radiate to the left shoulder or arm, plus or minus arm or into the abdomen. Worse on lying on the left side and on inspiration, swallowing or coughing. A pericardial rub may be present at the left sternal edge on auscultation. Causes of pericarditis are infection like Coxsackie virus and tuberculosis. Malignancies, uremia can cause pericarditis, MI, Dressler syndrome can cause pericarditis, trauma, radiotherapy, connective tissue disorders, and hypothyroidism. Investigations to be done in case of pericarditis is ECG. In the ECG in pericarditis, you find a concave or saddle-shaped ST elevation in all the leads. So, in all the leads, there will be an ST elevation and it will be concave or saddle-shaped. Management. Refer to cardiology. Treat for the cause if possible. Symptomatic treatment with NSAID for pain and steroids in resistant cases. Complications of pericarditis. So when you have a pericarditis, there can be a pericardial effusion, fluid in the pericardial sac, presentation, heart failure, cardiac tamponade, inability for the heart to dilate in diastole resulting in decreased heart rate, resulting in tachycardia, decreased BP and increased JBP, chest X-ray, large globular heart, echo is diagnostic, management, admit for urgent cardiology assessment. Constrictive pericarditis. Pericardium becomes fibrosed, non-expansile. Most common causes TB. Presentation is right heart failure, hepatosplenomegaly. Right heart failure, hepatosplenomegaly, ascites, decreased BP, increased JBP. Management refers to cardiologist for confirmation of diagnosis. Treatment involves surgical release of the pericardium. Cardiomyopathy and heart transplant. Cardiomyopathy is a primary disease of the heart muscle. Although some cardiomyopathies are unclassified, most fall into the following four groups. So in cardiomyopathy, you have four types. One is dilator or congestive cardiomyopathy. Prevalence is 35 in 1 lakh cases. Male is more predisposed to females. Dilatation of the left ventricle and decreased contractility. Usually presents with heart failure. May also present with arrhythmia, syncope, peripheral embolism or abnormalities on ECG or echo. ECG abnormalities are non-specific ST abnormalities. Chest X-ray, there is a cardiac enlargement and pulmonary venous hypertension. Echo is diagnostic. Echo is diagnostic for dilated cardiomyopathy. Causes are idiopathic 50% cases, familiar 20% cases, cardiovascular, either they have a previous ischemic heart disease or there is high BP, congenital heart disease, rheumatic heart disease, alcohol causes dilated cardiomyopathy, increased infection, Coxsackie virus causes cardiomyopathy, endocrine diseases, myxedema, thyrotoxicosis, acromegaly, endocrine diseases causing dilated cardiomyopathy are myxedema, thyrotoxicosis, acromegaly, cardiotoxic drugs, pregnancy, connective tissue diseases like SLE, polyarteritis nodosa, systemic sclerosis, sarcoidosis, amyloidosis, hemochromatosis, malignancy and muscular dystrophy. Management. Advise the patient to stop drinking alcohol as alcohol may make cardiomyopathy worse. Specialist management is needed in all cases and involves treatment of heart failure and arrhythmias, may require cardiac resynchronization or implantable cardiac defibrillator device. Most patients require long-term anticoagulation. Surgery. plasty or heart transplantation. Mortality is 40% in 2 years. Sudden death or cardiogenic shock is the cause of mortality. Then second is hypertrophic cardiomyopathy. It's an autosomal dominant inheritance, although 50% are sporadic. It's in its most common form causes asymmetrical septal hypertrophy plus aortic outflow obstruction. Hypertrophic obstructive cardiomyopathy or HOCM presentation. Most cases are diagnosed in childhood less than 14 years of age through an echo screening of asymptomatic patients with a family history. Symptoms and signs. Palpitations associated with arrhythmias, 5% have atrial fibrillation, breathlessness on exertion, chest pain, maybe angina or atypical chest pain, murmur due to outflow tract obstruction or mitral valve dysfunction, faints or collapses. Investigations ECG, left ventricular hypertrophy and ischemic changes, that is T wave inversion. There will be a T wave inversion. Chest X-ray normal until the disease is in late stages. Echo is diagnostic. Refer for suspicious symptoms or family history. Management and prognosis. Ongoing specialist care is essential to provide symptomatic treatment. Example, beta blockers for chest pain, amiodarone for arrhythmias, digoxin is contraindicated in HOCM. Implantable cardiac defibrillators improve prognosis for those at high risk of sudden death. Surgical options include septal ablation and myotomy or myectomy to debulk the septum and relieve the obstruction. Mortality, sudden death is unrelated to severity of symptoms. Restrictive cardiomyopathy. Rare. Stiff ventricle limits filling. Presence with heart failure. Echo is diagnostic. Causes are amyloidosis, sarcoidosis, hemochromatosis. Management is specialist management is required and treatment is symptomatic. Arrhythmogenic right ventricular cardiomyopathy. Rare genetic condition of progressive infiltration of the right ventricular myocardium with fibrofatty tissue, often asymptomatic until it presents with cardiac arrest. Refer any patient with a suspicious family history. Family history of sudden death. Refer so when there is a family history of sudden death, refer for first degree relatives of victims of sudden cardiac death who died aged less than 45 years to cardiology. Antenatal screening for familial cardiomyopathy and long QT syndrome is possible if a familial mutation is known. So in case people have a family history of heart disease, then antenatal screening can also be done. If family history of HOCM and no genetic test, uh, if there is family history of familial HOCM and still has not been genetic test has not been done and not detected, then children under 10 years of age, you need to screen with an ECG and echo every 3 to 5 years. Children aged 10 to 16 years, screen every 6 to 12 months. And if there's family history of HOCM, disease is likely to become apparent at this age, that is 10 to 16 years. Young people aged 16 to 20, screen annually. More than 20 years, screen every 5 years if family history and late onset hypertrophic cardiomyopathy is present. This is screening for HOCM. So you have to increase screening frequency in age 10 to 16 years, as this is the period when the onset of disease occurs mostly. Screening intervals are not established for other cardiomyopathies but should be adapted to the pattern of disease with that particular family. Heart transplantation considered in patient with estimated 1 year survival of less than 50%. Indications and contraindications for heart transplant is given in table 9.8. We will check that. Assessment. Each eligible patient is assessed for psychosocial factors and physical factors like renal failure, obesity, age, peripheral vascular disease, which affects the prognosis before a decision whether to place the patient on transplant is made. Post-operatively, patient require lifelong immunosuppression, usually with cyclosporine. Follow-up is undertaken in specialist clinic. Prognosis. 1 in 4 patients die on the transplant list. 60% receive a transplant less than 2 years. Perioperative mortality is less than 10%. 1 year survival is 92%, 5 year survival is 75%, 10 year survival is 60%. Patients have accelerated graft atherosclerosis. Complications of immunosuppression include increased risk of infection and cancer. Indications and contraindications for heart transplant. Indications are all patients must have an end-stage heart disease. Causes are ischemic heart disease 50%, cardiomyopathy 40%, valvular and congenital heart defects is 5% cases. And contraindications are Systemic disease likely to affect life expectancy, like patient has a malignancy. Active infection like HIV, hepatitis B or hepatitis C. Significant pulmonary vascular disease. Continued excess alcohol consumption. Significant cerebral or systemic vascular disease. Valve disease. Heart murmurs. Page 206. All patients with a newly detected valve disease, except with those with mitral valve prolapse or aortic sclerosis, require cardiology referral. Admit if suspected endocarditis is present. So new murmur and fever, admit. Refer urgently or admit if symptomatic valve disease or valve disease underlies the presenting condition. Example, you have a heart failure caused by aortic stenosis, atrial fibrillation caused by a mitral valve disease. So then you need to admit. There is a valve disease and it has caused some symptom. Then you need to admit. Mitral stenosis, usually due to rheumatic fever. Presentation symptoms are breathlessness, palpitations, and fatigue. May result in pulmonary hypertension, which presents with right heart failure, hemoptysis, and recurrent bronchitis. Signs are peripheral cyanosis, like malar flesh on the cheeks, left parasternal heave, tapping apex beat, atrial fibrillation, rumbling, mid-diastolic murmur at the apex. Management. Confirm with an echo, refer to cardiology. Treatment is medical. Treatment of atrial fibrillation, heart failure, anticoagulation. Medical. So mitral stenosis presenting. So with any other symptoms like AF, heart failure or anticoagulation. So that is the treatment. Plus surgical. Valvotomy, balloon valvoplasty or valve replacement. Okay, surgical is for the cause and medical is for the symptoms. Mitral regurgitation, incompetence. Its most common causes are congenital mitral regurgitation, rheumatic fever, mitral valve prolapse, ventricular dilatation, endocarditis, cardiomyopathy, ruptured papillary muscle or chordae tendineae during MI, following an MI or RA. RA is rheumatoid arthritis. Presentation. Symptoms. Dyspnea, fatigue. Signs. So mitral regurgitation. Symptoms will be dyspnea and fatigue as more blood is not pumped through the aorta. Signs. Displaced apex, left axilla, pansystolic murmur at the apex, radiating to the axilla, and atrial fibrillation, left ventricular failure. Atrial fibrillation is because there is dilated left atrium because of reverse flow into the left atrium, and there will be left ventricular failure. Management. Confirm with an echo, refer to cardiology. Treatment is medical. Treatment of either medical treatment for atrial fibrillation, heart failure, anticoagulation, plus surgical, that is valve replacement. Treatment is same for both mitral stenosis and mitral regurgitation. Mitral valve prolapse, prevalence in 1 in 20 patients. Presentation is symptoms, usually none, rarely atypical chest pain, palpitations, syncope, postural hypotension or emboli. Signs, late systolic murmur over the apex. It is not a pansystolic murmur as in mitral regurgitation, it's a late systolic murmur. Management, and there is no radiation of this murmur, whereas the pansystolic murmur in mitral regurgitation is heard better in the axilla, radiated to the axilla. Management, confirm with echo. If syncope or palpitations are present, refer to cardiology, that is symptomatic. A rare complication is ventricular arrhythmia. Aortic sclerosis, thickening and stiffening of the aortic wall not associated with outflow obstruction that occurs with age. Clinically, an ejection systolic murmur is present but no symptoms or signs. Chest X-ray may show calcified valve. No treatment is required. So this is age-related aortic sclerosis. So that's all for today's class, and we will continue tomorrow from page number 251. We will continue valvular heart disease. Thank you. Have a good day.